case? After every case you are doing this. Perfect, perfect. Any other those who are doing endoscopy? Sir? You are following the criteria, you are cleaning the scope or doing leak test after every case or at the end of the day? Once in a week. Okay, and still your scope is fine. Okay, perfect. So the pre-cleaning, the first step itself is a pre-cleaning. So once we withdraw the scope from the patient's mouth, the pre-cleaning has to be done at the bedside. Okay, this pre-cleaning takes hardly 1.5 minutes, maximum 1.5 minutes. But if we follow the technique and the steps of pre-cleaning, will ensure that removal of at least 99% of microorganism by doing the pre-cleaning at bedside in 1.5 minutes. So how should we do this? So for the pre-cleaning we do require the detergent solution. Now the specification for the detergent solution has to be, or before knowing that, I request you which detergent you are using, sir or ma'am, which detergent you are using? Which detergent solution you are using? No, that is disinfectant. I am talking about detergent. Savlon. Okay, I will show you some of the picture, those who has used Savlon as a detergent solution, how it affects the scope. Ideally Savlon is only foaming agent. Okay, the composition required for the detergent to clean the scope is something like neutral pH, low foam and enzymatic, and Savlon is only foaming agent, right. Now the specification of detergent solution is neutral pH, low foam and enzymatic, right. So this detergent solution at a pre-cleaning side, at least you should have 500 ml of detergent solution in a bowl. Okay, take a gauze piece, and once you take out the scope from the patient's mouth, wipe the outer surface of the scope 3 times. Now this wiping of the scope has to be in one direction only. It should not be like this. It has to be in one direction. Hold the distalent of the scope and throw the gauze piece. Again do it one more time and throw the gauze piece. It has to be done 3 times. Then the next step is remove all the channels, all the air water adapters, air water adapter and the suction adapter. Put it in the disinfectant solution. Okay. Next step. Then aspirate the air. Aspirate the air, suction. Okay. Aspirate the air, and okay, before that you attach air water channel cleaning adapter. Once you remove the suction and air water adapter, attach, there is a air water channel cleaning adapter in the standard accessory set. You attach this at this place, okay, and then aspirate air and detergent and then feed the water and air. Okay. The function of this particular air water channel cleaning adapter is the adapter which we regularly use during the case, there is a hole on this particular adapter. So air is continuously coming out of that hole, right. So whenever you wanted to inflate the stomach, what do? You just block that particular hole. That means there is only one opening for the air to come out, that is the distal end, and that is why the stomach get inflated. As simple as that, right. Now in this particular case, this adapter does not have any hole. So what does that mean? So from where this air will go out? From the distal end. That is the only possible way to come out, right. So whenever we attach this air water cleaning adapter to the scope, air is continuously traveling from both the channel, air channel and the water channel. Similarly, whenever you press this air water channel cleaning adapter, in the case whenever you press this adapter, what happens? Water comes out from the distal end, right. In this case, if you press this, water will come out from the distal end, but from both the channel, from air and water, both the channel. So this is the way how we clean both the channel, air and water. If you do not press it, air is continuously coming out from both the channel. If you press it, water will come out from both the channels. As simple as that, right. Okay. And then keep all the air water channel cleaning adapter, suction adapter, biopsy valve and air water valve in the detergent solution. Now the next point is leak test. The leak test is something like one has to perform after each and every case. Why? So sir, as you said, you do the leak test once in a week. Let's say if you have 5 cases in a day, or at least 2 cases in a day, right. You perform first case, and in that particular case minor leak has happened, and you haven't done leak test, right, but still you continue with the second case, and in the second case there could be the chances this minor leak may get converted into the major leak, right. That is the case. Now doing leak test is something like you must have observed how do we find out the puncture into the tire. The leak test is done in the same way. We inflate the air in between the channel and the sheath of the scope, okay, and we put it into the water. If continuous bubbles are coming out, we'll the leak into the particular point. So these are some of the picture which we have taken into the workshop. So corroded EL connector. So this is the maintenance unit which we do provide with one of our scope. And now there are another system like 170 system and 190 system. We consider wherever there is a light source is considered to be a potential source of air. We only require air for doing a leak test. So this we will separately provide you at the time of the installation. Apart from that, we do require air. Air is coming out from light source. So wherever there is a light, there has to be a cooling mechanism. So we do require a fan inside the light source, right? So that's why the light source considered to be a potential source of air. So we do attach this leakage tester to the maintenance unit, okay, and we check whether the air is coming out from this maintenance unit or not. If it is not coming out, do not attach it to the scope, right? Whenever we attach it to the scope, the distal end of the scope inflate like this. The expansion of the expansion rubber will happen. It will be look like this, okay. So you can easily feel the air at the distal end. Fine, and then you put the entire scope into the water. Perfect. Then observe for the 30 seconds. If the continuous bubbles are coming, that means there is a leak. Initially some bubbles may come, okay, but that doesn't mean there is a leak. Wait for the 30 seconds, okay. And if you observe there is a leak, continuous bubbles are coming, then remove the scope from the water immediately, right? But do not turn off the light source. If you turn off the light source, it means the air is not going into the scope. That means there is a chances of water can come inside the scope, right? So do not turn off the scope if you observe there is a leak. And do not attach or remove the leak tester while the scope is under the water. It has to be attached outside the water. So remove the scope from the water, turn off the MU1 or the light source, disconnect the leakage test, and after the air rubber return to the normal, disconnect the leakage tester, okay. Air rubber means this part. Once we detach the leakage tester and once it come to the normal level, then okay, then disconnect the leakage tester. Perfect. The next is manual cleaning. So in the leakage testing, what we have observed is there any leak in between the channel and the sheath? In between the channel and the sheath, is there any leak or not? This is what we have find out in the leakage testing. But in the manual cleaning, we'll do two things. First is to manually clean the channels of the scope, and second is to identify whether there is any leak inside the channel or not, okay. So first we will do the cleaning through the brushes, okay. So during the hands-on, have you ever observed there are two opening into the suction channel at two different angle, 45 degree and 90 degree? Anybody has observed? Perfect. So 90 degree, it means this particular part we connected to the, or this particular part at 90 degree considered as a suction, right? Perfect, because that is umbilical cord. At 90 degree there is an umbilical cord, right? This inside the umbilical cord there is a suction channel. But if we put the cleaning brush through the 45 degree, it will go through the scope, right? Now in a single channel scope, if you pass any accessories, okay, there is only one channel, right? Suction channel and accessory channel remains the same. So whenever you pass any accessories, you will not be able to do suction, or you should not do suction. That is something not recommended, right? So if you put the channel cleaning brush through 45 degree, the instrument channel will be get cleaned, and if you put it through the 90 degree, the suction channel will be get cleaned. So these are all the attachment need to be done during the manual cleaning, and you have to flush the water and the detergent solution through the channels. Then wipe out the outer surface, flush all the channel with air and water. Then we put the scope into the disinfectant solution. Now which disinfectant solution should we use? Which disinfectant solution you use, sir? Sidex. Perfect. So there are three different solution available into the market: Sidex, then OPA and peracetic acid. Okay, but usually we use Sidex, and we keep the scope into the Sidex for how much time? 40? 20 minutes, right, 20 minutes. So this time something specified by particular manufacturer. So depending on the manufacturer, you keep the scope into the in that particular solution. So soak the endoscope and cleaning accessories for the amount of time recommended by the disinfectant manufacturer. Then flush out the disinfectant after soaking and remove the endoscope from the disinfectant and flush with the sterile water and the air. Then rinsing is also important. So you wipe out outer surface of the scope with 70% of alcohol, flush the channel with the dry air and thoroughly dry the all parts of the endoscope. Then always hang the scope. Whenever, I mean in your routine practice, do not put it in the suitcase which we provide during the installation. Do not put it in the suitcase, always hang out the scope, because even if there is a chances of having a one single droplet inside the scope, so due to the force of gravity it may come down, but if you put the scope into the suitcase it will not. So that may create moisture and that may damage your CCD over a period of time. Thanks a lot. Thank you. Any question? Those who are doing endoscopy, please sir. Solid detergent. So there are two detergent solution available in the market. Company called 3M and company called Johnson & Johnson. They do provide. The product name is Sidezyme and Rapid Enzyme. These two products, they do have these all specifications: neutral pH, low foam, and enzymatic. The composition has already been given onto the bottle. Yeah. You need to have 3 different tubs. Sorry? There is no need to dilute with water or something. I need to check with the composition. Sorry? Leakage test. Leakage testing. Repeat. Okay. Same slide. Actually, we were about to show the physical demonstration, but for all the crowd, it's been difficult. Okay. Fine. Tomorrow morning. Okay. So tomorrow morning we'll cover it physically. Okay. So we'll demonstrate how to do the leak test. Right. Thank you. Surely. Perfect. Thanks a lot, sir. Thank you.
Yeah. No, it should automatically will play. We'll see. If it is not working, we'll make some money. You just open the folder. It will usually the PowerPoint. Right. Okay. Good afternoon. We'll have a tea break, or we'll have a tea served during the session, Samir, if you want. So this is another important lecture. I mean, all the lectures are important because we have trimmed all the unwanted lectures. Everything is practical. The minimum theoretical background one has to have before taking the fellowship examination. I understand this time this course is unique in different ways, like having a smart lab. Again, there are more non-exam category than exam category, I can understand. But we have prepared an MCQ that is optional for the non-exam category, but it is essential, it is a prerequisite for the exam category. So, but everybody can, I will give a paper to you once all the lectures are over at the end of the day, and you just the marks are, because at least you know where we stand. It is like a post test, so don't take it. Even if you are senior, it is always nice to see where we stand, whether the topic, because it is one way of, we are actually making a feedback form, see whether we need to change the lecture modules, and how much. So it is more than for you, it is for us, it's beneficial. So I encourage all of you to take that MCQ, whether you are whatever category, that's my request, but it is an essential for all exam category. You have to take it, okay? And next important, this is endoscopy pathology. The best way to read it, you go and see the book, because we have taken, because there are a lot of pathologies we can't cover in the given time, but at least we know how to understand all the topics. So on page number 55 or 57 to 90 or something, you just, all of you have the book open in front of you now, because we are now going to make it really interactive. I am going to ask you some questions. Randomly, I am going to call some names so that I can know face to face who are all we are meeting today. This is one way of, I am not trying to put you on the spot, bother, don't worry. And we have a revolving mic, and we have a mic so that they are going to answer. So one person can stand with a mic. So whoever is standing, they will be given a mic to answer. So this is the way we go. It's like a, okay, endoscopy pathology chapter, because we as a surgeon, we understand the pathology on the background of the patient's clinical history. Imagine a patient comes with upper abdominal pain, burning sensation, then you say it's a dyspepsia. So what are the causes of dyspepsia? If I do endoscopy in this patient, what are the possibilities, you know? Or if a patient, elderly patient comes with a difficulty swallowing, progressive weight loss, significant weight loss, you think probably is a carcinoma esophagus first in your diagnosis, and achalasia next, and slowly other things. Like that, you need to have symptom-based serial various differential diagnosis as you do endoscopy. Okay, that's a very important thing. That's the way we see. I'm not going to say these are the pathology in the esophagus, stomach. It is not geographical description. It is a symptom-oriented, patient-oriented. So, for example, a case of dyspepsia, okay, I am having. So, this is for you. Okay, so here is a. So you have to take the mic and tell me. Okay, so I am going to. So this is the still picture of various places. You tell me. We are all taken.
Sir, that is taken at the level of cricopharynx.
Tell me what is this area?
Piriform fossa.
Which piriform fossa?
Right, sir.
Well done. This, what is this?
Vocal cord, sir.
Vocal cord. What is this?
Z line, sir.
Okay. And here, see, is already given nicely. Okay. So where is the pancreas will be seen. Or if at all there is a pseudopancreatic cyst, where it will be bulging? Here, here, or here, or here. At what clock? Say the clock position.
3 o'clock position.
3 o'clock position. Good. So here is the incise. So you have seen all lesions, and this is the bulb, and this is the D2, and this is the ampulla. So we have seen almost, and everything is normal in this patient. So here is a dyspepsia with a normal endoscopy. So how to write the diagnosis? Will you write?
Endoscopic diagnosis.
Yeah, you have to do the report. So you have to.
No, everything esophagus.
Everything normal.
Yes,
because 60 to 70% of your endoscopy is going to be normal. Okay, that is the reality when you do endoscopy. And but the patient always says, then why I am getting pain, sir? Patient is going to ask.
Further investigation you have to do. No?
Of course, if you do an ultrasound, that is also normal. That is also very often you see in young people. Then there is a functional dyspepsia. So you have to write that. So functional dyspepsia forms a large proportion of your case volume. That first of all we need to realize. Okay, that's what is the first slide about. Have a seat. Next important cause is if the patient's dyspepsia is more of a reflux type, retrosternal discomfort, pain, or belching, if it is there, then possibility of esophagitis one has to consider. And esophagitis, most of the pathology is just above the Z line. Okay, you see various degrees of esophagitis. There are various causes, but for vast majority is GERD. That is what we should all realize, GERD, even though there are other causes are eliminated there. But the most important thing is there are 4 or 5 classification we need, because the what important thing I wanted to stress is the internationally accepted standard medical terminologies we should use. If you are giving one report today, even if it goes to Europe somewhere and they are seeing that is as per this Los Angeles classification or Savory-Miller classification, this patient has a grade 2 or grade, like that you need to write. So that is what you need to. So only by just memorizing, reading, seeing various atlases. Okay, and this is just I'm comfortable with the Savory-Miller classification for esophagitis, which is classified into grade 1 to grade 4, 1, 2, 3. So as you can see here, a column of inflammation. Here all the columns are confluenting and it becoming circumferential. So, grade 1, 2, 3, but what is important, and we are getting more complications. A complication of esophagitis, that is, for example, an ulcer, or going for a stricture like a peptic stricture, or even going for a Barrett's change, that is the metaplasia, going for a Barrett's esophagus. All these three are actually, as for the Savory Miller, it is a grade 4 esophagitis. So, we should be able to know the grades. So, that I request you all to go meticulously the book and try to understand that and use it every day. Okay? But all of you should know there is an entity called endoscopy negative gastric esophageal reflux disease. For example, if I have a severe reflux, I take PPA today and tomorrow, and if you do endoscopy, it may be normal. But still, you have to admit, because of the symptoms, you treat it as GRD. Really, you have to stop PPA for at least for 2 weeks and send them for this study. In ideal world, this is a test of choice. Okay, dim is the criteria, and you see and treat accordingly. So that's the thing. And corrosive poisoning is the next entity. As a surgeon, one may have to do. Okay, so let me see whether the videos are not running. So when you have a corrosive poisoning, for example, a 13-year-old girl, because she didn't do good in the exam, she drank something in the bathroom, is coming to the emergency, and emergency resuscitation done, airway is okay. Now they are asking you, because you are the only endoscopist in the hospital, they are asking you, can you consider endoscopy? Will you do endoscopy in corrosive poisoning? First question, yes or no. If you are going to do, when your ideal optimum time of doing it? Mike, please. Yeah. Yeah? So you do an endoscopy. So what do you achieve by doing endoscopy in a corrosive poisoning?
Ulceration.
Yeah?
To see any ulceration.
Okay.
Necrosis.
So in other words, endoscopy is essential provided it is done early. Patient's airway is stable, you do preferably within 24 to 48 hours. We can grade the severity of inflammation, because corrosive poisoning is actually graded into grade 1, 2, 3. Redness is like burns. So you know the burns also first degree, second degree, third degree, similar one more or less. Okay, so the first degree is like a hyperemia, redness. It vanishes within few days, couple of days or 3. Some ulcerations, they are more prone for stricture formation, corrosive stricture. What we are worried about is the third degree, that is a complete necrosis. That patients we need to recognize, because their risk of perforation is there. So okay, so that's, and what is during endoscopy, what is a very important thing one has to understand, what we should not do, because it has to be done preferably by a person who has done it several times, experienced person. The reason being very simple, minimum insufflation, because if you keep on insufflating, then there is every chance of this sloughed off going for a perforation. So minimum insufflation, sleek, very swift endoscopy one has to do in a patient. So that sometimes we do it in the ICU itself. Okay, and then if everything is favorable, we even leave a Rayleigh tube, because that will act like a place through. Then we can take the Rayleigh tube after 3 to 4 weeks later, then do a dilatation if necessary. For feeding purpose, we pass the Rayleigh tube immediately, because you know the acid and alkali, various damages, we can go on and on, but at least you should know when to do, what to look for. Okay, have a seat. The gastritis, most of them report, I usually see, or most of you might have seen, mild gastritis, severe gastritis, they usually give a report, or gastritis 1+, 2+, 3+, like that. That reports are not valid. Ideally, the gastritis has to be described in 3 steps. 1, how extensive gastritis is, anatomically, whether the whole stomach or proximal stomach or antrum of the stomach, like that. Second is like any inflammation or tumor, whether it's mild, moderate, severe. That's the thing. And the third important is pathological classification, whether it is a gobblestone, edematous mucosa, or redness along the rugal folds like this, or is it patches of hemorrhage like this, or some change, loss of mucosa like erosions. So edematous, erythematous, hemorrhagic or erosive gastritis. So if you say a patient may have a total, moderately severe, total hemorrhagic gastritis, like that, all the terminologies add together. The computer, if you add everything, it will come with a complete diagnosis. So try to be as descriptive as possible. That's what we are telling. And these are the terminologies normally accepted internationally, because that gives you an idea. For example, this is very typical. Erythematous gastritis, this is very typical in alcoholics. Some hemorrhages can happen in people like people on aspirin or some drugs like this, or erosions also. Okay, and there are chronic gastritis sometimes more predominantly in the distal part. That is distal stomach, it is more H. pylori. Proximal part, usually, for example, parietal cell damage like a pernicious anemia. So type B and type A gastritis. That is they are also classified also that way. But no. I mean, you can use antral gastritis except the term. Either antral gastritis or distal gastritis, both similar. It takes. What you should do is there is another entity called gastropathy that one has to understand. Okay. So what is, have you come across these terminologies already? Gastropathy. Yes. No, that is a gastroparesis. What you are telling is a gastroparesis. Gastropathy is actually a congestion. It also will look red. See, gastritis is also red, here also red, but there is the inflammation, here is not inflammation, it is a congestion. If you have a venous congestion of the gastric wall, then the whole thing will look red, but the redness will look very different. It may be the whole thing looks like a skin of a snake or a crocodile like this. Okay, thick mucosal details will be seen like this, or it will be like as if you cut a watermelon like this appearance, typical redness. Okay, converging onto the pylorus like that, watermelon stomach, or it may be crocodile stomach like this. Okay, so these are the two types you have to think. So that is called this is important to recognize for simply for two reasons. One ought to not to take biopsy. Biopsy is usually forbidden in this ideally, because this is in the background of chronic liver disease. These people have chronic liver disease, coagulopathy. If you take a biopsy, it is going to bleed. It is not going to give you any answer. Whereas gastritis, you tend to take a biopsy. So as soon as you something, is it gastropathy? Then you will be hesitating to take a biopsy. So that's why you need to aware of this diagnosis in a chronic liver disease. Okay, thank you. And of course, an ulcer. See, for example, here is a patient with an ulcer. Can you describe the ulcer as that? We as a surgeon, we know how to describe ulcer anywhere in our body. So how will you? Where exactly? Site. Yes.
Antral region, ulcer is
how big is
covered
it?
by slough.
How big is it?
Around 2 into 1 centimeter ulcer.
Is it 2 centimeter? How many of you say it is less than a centimeter? How will you measure an ulcer? You all less than a centimeter, raise your hand. 2 centimeter, you who agree with him, raise your hand. So only one person is agreeing with you. So in other words, in the beginning, because everything is magnified, isn't it? If I put the same, even a bigger skin, it will become 4 centimeter, isn't it? So you have to have an index. See, always you have in the beginning of your career, take a biopsy forceps and open the biopsy forceps. Okay, the open biopsy forceps from one end to the other end is about 8 millimeter to 10 millimeter. That is about a centimeter. And some biopsy forceps will have a spike in the middle, and half of the biopsy forceps half a centimeter. So you take every time an ulcer is there close, go nearby and measure it, eyeball. It is like taking a scale and measuring each and swelling. After some time, you need not have any biopsy force. Without that, you can be diagnosed. So in the beginning, you have the habit, because even when you have esophageal stricture, I want to know. I take the biopsy forces open and see whether it is smaller than the biopsy force. Open biopsy force means the diameter is less than a centimeter. Like that, you will be able to know. So this is the. So here there is a pre-pyloric ulcer. This is a pre-pylorus, pre-pyloric ulcer, or as you rightly said, antral ulcer. Is it along the greater curve or lesser curve?
It's around 6 o'clock position.
Yes. So it is along the. So this is the greater curve, and that is a lesser curve areas. Okay. So more. What about this ulcer? How big is it? This way, from here to here. You are out now. This is 2 to 2.5 centimeter. Okay, it is actually, this is the pylorus. It is above the pylorus. It is actually pre-pyloric, just below the incisura.
Lesser curvature.
So this is the one of the commonest site. Any ulcer more than a centimeter, actually more than a 2 centimeter, definitely you suspect malignancy. You have to take a biopsy from all the edges, multiple biopsy. Minimum 6 to 8 bits you have to send. Okay, don't take it from here. So you have to take it all around from here. Okay. Have a seat. Next is a duodenal ulcer. For example, here is an ulcer. Where exactly the ulcer, sir? So this is anterior wall, this is posterior wall, this anterosuperior wall. It is actually something, some ulcer is extending as if it is like a kissing ulcer. It is both walls. It is one of the common site is here, anterior ulcer. And what about, these are all the very typical appearance of erosions, severe duodenal erosions. Again, you can see here. And whenever you have a duodenal pathology, most of the time in the D1, they are mostly benign. You need not take any biopsy there. You come back into the antrum and take a biopsy for H. pylori test. So what is the basis of H. pylori test? If you know already, please tell me, otherwise we will describe. H. pylori test. Why we do it, how we do it, and how we interpret it.
To detect the presence of H. pylori in the antrum,
Yes, sir.
we take small bits of antral mucosa.
Yeah, one bit is enough. Yeah.
And put it in the medium.
What medium?
I don't know.
Yes, it is available in various forms. There is some as a bottle, but nowadays it is available as a RUT test, rapid urease test, is a slide form where there is a small disc is given. That disc contains what? Yeah. Urea and in the indicator, phenolphthalein indicator, provided the specimen has a H. pylori, the H. pylori will release urease. That urease enzyme will convert the urea to ammonia. The ammonia being alkali will convert in the presence of phenolphthalein from yellow color to pink color. So pink color, how soon you will get the result?
Immediately.
Within few minutes. And how specific or sensitive it is? It is a very highly specific and highly sensitive test. Only negative one is invasive. One has to do an endoscopy. Can you tell me a test which you will do in a patient who doesn't want an endoscopy done? A very specific, non-invasive test available. Urea breath test. So that is the alternative for this. Okay. So there is an invasive specific test, non-invasive specific test. You should know both of them. Okay. Next, sir, if you don't mind, can you tell me where is the lesion and can you describe the lesion?
It's an ulcerative lesion, sir.
Yes. How big is it? And where exactly it is?
It is in the, probably in the radius at which
How we are able to see? Which maneuver we are able to make you see?
J maneuver.
So only on J maneuver you are able to see, the scope is seen,
Yes, sir.
and you are able to see the cardia part. But this part is lesser curve or greater curve?
Sir, that is the fundal part, I believe.
No, this is fundus is here. Okay, this is actually towards the lesser curve.
Yes, sir.
Okay, so this is the cardia extending onto the lesser curvature. What is close to the scope is lesser curve. What is away from here it is a greater curve, and this is the fundus. This is the cardia. So there is a large ulcerative necrotic looking tumor, more than 5-6 centimeter all around is seen, highly suggestive of malignancy. So here taking a biopsy itself is a challenge, because in a J maneuver you can't take the biopsy forceps. So you straight scope is in the antrum, take the biopsy forceps. Then gently do the J maneuver, reach and take a biopsy. Then again straighten the scope, come out. So every time you have to do 5 times. So sometimes it's very cumbersome. That's why some companies have designed the biopsy forceps, which on one go it will go, take 1, 2, 3, 4, 5 bits and take as a one go. Sounds exciting, isn't it? So that is called multi-bite. There is a multi-bite Boston Scientific they made. So because it has a small cylinder, so all the force biopsy specimen is hidden there. Then you take it out and then 5 times you push it, all the things are vomited out from the biopsy forceps. So all awkward places, rather than doing 5 times in and out, instrument exchange, one exchange you can do the biopsy also. So in other words, get to know various accessories available in the market, and depending upon the difficulty level you can ask your staff, get me that biopsy forceps, because here it is very difficult to go all the way, like cecum, you have to go all the way to cecum every time. You go there, 5 time bite, take the whole thing out, finish, job done, one go, job done. Okay, so that's about the multiple biopsy by multi-bite biopsy forceps. And there is a way to describe the malignancy of stomach. We don't recommend all the time. It is possible, try to be descriptive, because some tumors are like a Bohrman polypoidal or ulceropolypoidal or ulceroinfiltrative or Lionidis plastica. like that there are some. So you try to be descriptive, expressive. Very important is sight, size, extent, how far it is away from the cardia, because that only is going to determine the surgeon. Okay, like okay, thank you. Next is a dysphagia. Yeah, that's so this is the H. pylori kid. Okay, this is what available. So what is the small disc? So we take the specimen, put it here, and put a drop of saline, and put the patient name, leave it aside. By the time patient comes to the consulting room, the results will be ready. So the result indication is also there. Say red means what, green means. So it's nicely. So it's about less than 70 rupees or so each slide. And this is what most important thing. An endoscopy for a patient with the dysphagia. Anybody coming to dysphagia, endoscopy has to be done on the same day. Don't postpone it. Okay, dysphagia very seldom functional. It is not like non-dyspepsia, where 60% of the cases will be normal. Here, almost always you see some pathology. Okay, what pathology? It may be in the lumen, in the wall, or in the outside the wall. We know all the classification. I need not dwell into it. History will tell everything. Classical persons. You have a patient, elderly man, had some restaurant food, left his teeth, and he swallowed in a hurry, then comes back with the food sense. So short, ultra short history within a day. Foreign body. Okay, all different types of foreign body. Which is the serious one? For example, who is the next? Yes. So I'll tell you. For example, there is a coin, foot bolus, and a fish bone. Don't worry about that. Out of these three, which is serious one?
Fishbone, sir.
Why?
It may perforate.
Yeah, it's already perforated. As you can see, it's impacted. As you can see here, it is impacted, and exactly at what level you should be very careful. Okay, disimpacting and taking a fish bone maybe sometimes it will be in horizontal, impacted on both sides of the esophagus. There are awkward places. So fish bone, don't take it lightly. It can be very, and also open pins also dangerous. For example, this is like this. So how to take it is a challenge. For example, here ideally speaking, you catch hold here, push it all the way in, reverse it, then the sharp end should be trailing. You know, foreign body removal, the base thing is sharp end should be trailing. That is the way. Or you should have something like an over tube over the endoscopy. In other words, patient already had an accident, he should not get another accident by you trying to do. Perforation during removal of foreign body is a real possibility. So one has to avoid it. Only thing is you have to rehearse what's going to happen. So all this, see for example, dentures with the sharp end, as you can see, fish bone and open safety pin, you have to see what you are going to do. Plan accordingly, get the right accessories. If necessary, as I said, drill is go. Don't hesitate to push the foreign body in, reverse it, take it out with some gadgets are available to cover the end of the stomach, like a fundal hood and things like that. Okay, we'll discuss later. Foreign body, it's a discussion tomorrow. Okay, and this is the one is a very typical if it is present like candidiasis. Okay, patients as if they had a yogurt a minute ago, but only difference is here it cannot be washed away easily. There will be underlying hyperemia. Okay, and strictures of various things. Post-cricoid web. Have you seen that entity being described in the books? Post-cricoid web. Very typical patient, a 30-year-old lady, chylomicria, anemia, glossitis. They'll come with a foreign body sensation. Yes. Every time I take a tablet, it's sticking, sir. So you go. That is a notorious patient. You may not be able to enter the cricopharynx because this one will prevent you to enter further. The one way is endoscopy. You go up to here. Don't pass it forcefully. You will be tempting to do, but you will perforate. You pass a guide wire. Okay, there is a guide wire is there, okay, with a floppy tip guide wire, and over the guide wire you pass the endoscopy. The endoscopy will act like a dilator. So that is a very simple way. It's very simple provided you have a dilator. Under vision you dilate. It's like a endoscopic intubation with a bougie on. See, similar thing. So post-cricoid web. Okay. Next is all these things. Okay. Sorry. Corrosive stricture. Again, it can be simple or could be tortuous. Peptic stricture, very common in the lower end on GRD patients. Various types of benign strictures. Okay, and this I don't know, the video is not running. Just click on that video. If it's running, it's fine. So the video will run it later. So what is important in achalasia? You have to recognize everybody of you. Whenever you do endoscopy, if food or fluid is in the esophagus, it is abnormal. Okay, I told you in the morning itself. And it is a dilated esophagus, and there is a food and fluid, and you do J maneuver, then the cardia looks normal. Okay, so these are the characteristic features of achalasia. Okay, have a seat. And recognize these entities also. For example, sometimes you will see a normal looking mucosa, something submucosal lesion. What you should not do is try to take a biopsy. It is a futile attempt. Neither it is going to be representative, and you have, spoiled the opportunity of trying to remove it endoscopically at a later date. So always when you have a submucosal lesion, whatever it is, record size of it, site of it, and submit them for further investigation. The investigation of choice nowadays is, of course, endo ultrasound or a CT or MRI in some cases. Okay, and malignant stricture, of course, the malignant strictures, okay, will come from the back randomly. Yes, gentlemen, postgraduates, you are okay. You are in the course, or ma'am, we'll start from the ma'am. See, whenever you have a carcinoma esophagus, what are the data you need to put it in this? For example, you are seeing a lesion around a patient with a progressive dysphagia is coming, you are doing an endoscopy, there is a tumor started appearing at 20 centimeter. So what you should ideally do? If possible, you go further down. Okay, you have to go further down and see how extensive it is. In other words, the length of the tumor, circumference of the tumor, and any associated complication. Exactly, you have. And if it is a lower esophagus, you have to do J maneuver and see whether it extended onto the stomach also in the cardia. All those details you have to be described. So the length is very, very important. Okay, from what level to what. For example, 15 is the cricopharynx. Okay, 15 to 20 upper esophagus, 20 to 30 middle esophagus, 30 to 40 lower 1/3. So just make it upper 1/3, middle 1/3, and lower. And upper and middle always suspect whenever awkward looking place or patient says every time I eat I cough a lot, suspect tracheoesophageal fistula, especially in the upper and middle. So there is a possibility. Okay, you have to always suspect that one. The best is to do other investigations like a CT. Okay. Okay, then rarely you will encounter this type of unusual pathology like Zenker's diverticulum. As you enter the cricopharynx, one lumen and two lumen. It is like two ways, which way to take it, this route or that route. But one route, if you every time when you go blind, it is a blind pouch. And this is the, so I have to identify. Zenker's diverticulum is the one thing. It may be very difficult for a beginners to enter the right route. Okay, one has to recognize. And the bleeder is the next important thing. Have a seat. Then the next pathology one has to well versed is upper GI bleeding. These are the common causes in our country. I have enumerated. In the esophagus, these are the three common causes with a typical history. As I said, history is most important thing. Beware of a patient, a known alcoholic coming with the retching. Fourth time he vomiting blood, Mallory-Weiss syndrome. Patient, alcoholic for 20 years, suddenly on fine day he vomits sprang blood a liter, esophageal varices. Okay, like that the history will tell you exactly what's happening. So it's not that difficult. So stomach also various causes I have enumerated. The challenging cause or the things often missed, I'll tell you, is a fundal varice. Because J maneuver, when you do in a patient who is bleeding, and the fundus will not be seen because the clot will be sitting in the fundus most of the time. So unless you suck the clot or change the patient position, you will miss the diagnosis. So the fundus is the difficult area in a patient actually bleeding. That's why people say, I'll repeat the endoscopy after 24 hours like that. Always redo the endoscopy. Or if you are really good irrigation system, there are various ways of looking at the fundus. I'll come to that in a minute. Okay. For example, here is a esophageal causes like a Mallory-Weiss, usually above or below the OG junction. Okay. But what is most important for all of you is recognize the presence and severity of esophageal varices. Okay. Don't say big varices, small varices, or short one or long one. All those terminologies are not enough. We have to grade them, grade 1 to grade 4. Okay. I will try to grade and try to understand, and it is not difficult at all. Grade 1 is this one. In other words, grade 1 is so small. Okay. When you insufflate the esophagus, right in front of your very eye, it will start disappearing. Okay. You saw it. but it disappeared as you insufflate because it's flattened out. The esophagus will flattened out. That is called a missing varices. Whereas the other one, the other extreme is kissing varices. In other words, even after insufflation, there is not enough space for you to navigate into the esophagus because everything is kissing each other. The lumen is occluded by big bulging varices. So missing and kissing is grade 1 and grade 4 easy. The middle part is grade 2 and grade 3. There the size matters. Size less than 5 mm, more than 5 mm. Okay, how will you know? For that, ideally a biopsy forceps will give an answer, but don't take a biopsy forceps and try to middle with the esophageal varices. It's like touching a sleeping tiger. Hello, how are you? So don't do that, but it will tell you, because I'll tell you the importance of biopsy forceps when it comes to fundal varices. Okay, so this is the way we diagnose. So grading is important, and how many column of varices present. And another thing, usually we are very fond of, but only by experience you will know the importance, is to look for these two signs. Okay, what are they? I have written here cherry red spot and a red wale sign. Okay, what do they indicate? They indicate the varices actually are submucosal. Okay, most of us varices is mucosa is there, submucosal. Whereas these two means the varices are within the mucosa, that is intramucosal. Because you know it is a stratified squamous epithelium. Within the few strata of epithelium, there are some dilated blood vessels, intramucosal. So they give some red spot, that is called cherry red spot, or some streaks of redness. So it is the spots of redness, that is streaks of redness, like a whale's back of a whale. So that's why it's called red wale sign. So these are notorious signs for early bleeding, indicator he is going to bleed tomorrow or day after. So these people have to be taken seriously, have to be treated preemptively, even before they bleed, because when they bleed, it is very difficult to control. Okay, that's about them. And of course, this is what I told you, the fundal varices. It is like grapes hanging on the roof. They look like it. But a differential diagnosis is a GIST tumor. It could be GIST or some leiomyoma can it be. But there is a difference. This is blood filled, so it will be compressibility, yielding sign will be positive, whereas if it is a tumor, it will be firm to hard in consistency. So what we do is, if you are careful, you take a closed biopsy forceps, gently go and probe it. And its yielding means it's probably a fundal varices, but by look, most of them by experience you will know, but otherwise you can do that. But ideal world, you should do an endo ultrasound. Endo ultrasound will tell you exactly blood filled column or it is a tumor. Okay, so but fundal varices will look like this. And if there is a clot over it, you may miss it. So always you consider this. And these are all the other rare, but take it from me, carcinoma stomach seldom bleed and present rarely only as a hematemesis. They present only. So hematemesis, don't think cancer as a cause. If at all, it will be this, or if at all the rare cause, common cause is leiomyoma with its summit bleeding. Large leiomyoma, like a volcano eruption, at the summit it may bleed. That is the only reason. Otherwise, tumors unlikely to bleed. And one of the rare condition, but always worth remembering, because always the rare case comes first, as the first case is come to you. So is a dilophoid lesion. Okay, this is another condition. I ask you all, okay, keep a note of it and try to read a little bit more, because why it is important? Because when I do an endoscopy in any bleeder, okay, patient is blood vomited 6 hours ago, I do an endoscopy, only 80% of the people I will be able to see a lesion. 20% of them will be negative endoscopy. The 20%, 10% because I missed the lesion, or the 10%, probably the lesion has healed by the time because of delay or some other thing. But the 10% of the lesions are these are the lesions. One is a dilophoid lesion because there is a tiny arteriolar bleed, usually high up in the lesser curve. So these people carefully, if you scan the stomach meticulously by experienced endoscopists, they will be lucky enough to spot this bleeder, because if it bleeds actively, it will be like a spurter, eminently treatable either by a hemoclip or by an injection. But if it is seen to be, so we have seen 2 or 3 cases in the last 15 years, that is a long time, but still it is all interesting cases to observe. Okay. And a duodenal ulcer bleeding, okay. And the bleeding ulcers, when we have, there is a special classification you are recommended to classify them, that is called Forest classification. Okay, I have already said Savory Miller, Borman classification, then for varices grade 1 to grade 4, and this is the final classification, that is a Forest classification, 1, okay, 2, and 3, and 1 again subdivided into AB, 2 again into ABC. But don't worry about that. What is important is grade 1, bleeding actively. That is, you do endoscopy, the ulcer is actually bleeding right into your very eye. That is active bleeding. That is 1. 2 is it bled yesterday. It is not bleeding now. It might bleed tomorrow. That is a lesion is called 2. 3 is which is not going to bleed at all. So grade 3, they go to the ward because they are never going to bleed. 1 actually bleeding, you don't leave the patient, you treat it. And grade 2 is debatable what you are going to do. So like that. So they have classified. It is nice, interesting. There are various pictures are available, like actually bleeding. If it is spurting arterial bleeding, A, and oozing, that is venous ooze, it is B. So A and B, the difference is whether it is spurting to the roof or oozing like that. And as I said, 2 is potential bleeder. As potential bleeders, that blood yesterday, because of all the hypotension, all the things you have given, they have stopped bleeding as of now, but it might bleed tomorrow. So you have to. So that is, there are various descriptions are there. I don't want to dwell the fag end of the day. You can all read it up, but that is actual bleeder. This has to be considered and treated. Okay. And there is actually a small video. We'll run it at the end of the class. And the last one is atypical chest pain, because patients angina type of pain, they go to the cardiologist, echo done, everything normal, they come to you, and you have to suspect motility disorders, hiatus hernia. This is a very classical sliding hiatus hernia. Pictorial representation. Endoscopically, as you go, this is the Z line, and this is a hiatus. You will be able to see the distance will be more than 2 centimeter. J maneuver, you can see a large gap is seen. And there is a prolapsing gastric mucosa. So all these things are, some of them may be present. So these are the different types of hiatus hernia. Type 1 commonest, type 2, type 3, type 4 can happen also. Okay, and this is a paraesophageal, like a, looks like a diverticulum like appearance like this. Okay, and motility disorders, always consider manometry also in your algorithm. I said endoscopy, pH study, manometry, everything comprehensively called. You have to have run like something like an esophageal lab. Everything is done. Now high resolution manometry is available like this, a pictorial representation. Interpretation in the beginning may look very daunting task, but I am sure once you start seeing achalasia and things like that, it is not that difficult at all. So you consider manometry in all cases of fundoplication or achalasia cardia before you intervene. Okay, and gastric outlet obstruction. Okay, and polyps, sessile polyps, pedunculated polyps. Don't think polyps are only in the large bowel. It can happen also in the stomach, especially when you have patient with some disorder. Okay, and post-operative stomach. That's why another important history, because you might have done a GJ 10 years ago. Patient comes with a bilious gastritis. You have to understand which is the afferent lobe, which is the efferent lobe endoscopically. That is very challenging. Okay, and you might have done a nice fundoplication, Nissen's wrap, how it will look endoscopically. Or you might have done a bariatric procedure, patient comes with some problem. In a bariatric patient, doing an endoscopy is challenging. So they are all by themselves, there are big topics. I am just introducing you to the topic. So all this pathology one has to see. But what is most important for all of you, the last slide, is understanding Barrett's esophagus. Okay, because that's coming the, so you should know how to see, recognize Barrett's, how to measure it, and what you do with the Barrett's. Okay, that is the thing. So we know what is Barrett's, I need not dwell. There are various ways of identifying Barrett's. White light endoscopy is what we do every day. But narrowband imaging, if it is available, it will tell you exactly all the tongues of creeping Barrett's mucosa into the esophagus. You can easily identify. You can target your biopsy. So narrowband imaging, if it is there, welcome. If I don't have, I have only white light endoscopy. What do you do? Ask me. You go for what we call a chromo endoscopy. What is chromo endoscopy? The same axion endoscopy, whatever conventional endoscopy, but you spray the esophagus with some contrast, like Lugol's iodine or methylene blue. So that will distinguish a different color. It will give different color. So by spraying the contrast, using your own conventional simple endoscopy, we can do a procedure that is called a chromo endoscopy, or endoscopy itself is having the image enhancement technology, that is narrowband imaging, depending upon that. And now we go to this extent, confocal, electron, endomicroscopy, all these things. Okay. And there are two types of Barrett's, short segment, long segment. Definition is how long and how short, less than 3 or more than 3 centimeter. Okay. And how to measure it? There is a ways of measuring it. The main important thing is you see where exactly the top of the rugal folds end. Okay, from the, this is the end of the rugal folds. So from here you just circumferentially up to here and vertically up to here. So circumferential part up to here and vertical for tongue like projection how far you have to measure. So from here you measure. Okay, so there are various ways of measuring the Barrett's, and this is the varices how they look before banding, during banding, after banding. You have to recognize all these things. So for endoscopy pathology, we can't finish in a single day. It is a, you have to, it's a lifelong experience. You have to see various atlases and collect all your pictures and put it in a folder like esophagus, stomach, like that you prepare, and it will be useful to for you and your juniors. But very important thing is, before you dwell into the pathology, always apply your knowledge with the background of the patient's clinical findings, both history and examination. Then you describe the finding as the international standard. Always document. When you are not sure, you discuss with your mentor or go to the atlas either in the cyberspace or whatever books you are having. That way only you can just fine tune your experience in pathology. Okay, thank you. That video we will run it later. It is not important. We'll go for SARS lecture.
Okay. The popular. Set mobile side by difference. Table.
Okay, you've gone through the entire gamut of pathology in the esophagus, stomach, and duodenum. All right. It all has been a straightforward description of how it looks like when you put in your scope. What I'm going to tell you is that there are places where you have got to have some innovation in what you have to do, which is this one. Okay. So, when you talk of tips and trips, all that I would like to say is, it is not like passing a Riles tube into the stomach. Okay? The gastroenterologist Radio 1 had a photograph of a ward boy holding a stomach tube, putting it into the stomach. It is mainly the identification and interpretation of the visuals that you are shown that are important. The last line is most important. What your mind does not know, your eyes do not see. So it's very important that you are exposed to all photographic impressions that have been printed. There is also a number of books with photographs of the pathology of the GI tract, which I think all of you should go through to recognize lesions that come to you. There is another one with us in the Efiages group, that when you do an endoscopy and you find that there is a problem which you are not able to explain, you can transfer it to our our WhatsApp group, and the senior endoscopist will help you to clarify what that pathology is, or will advise you what to do next. Now, first of all, you should know why you are doing an endoscopy. It is not that every patient who comes to you with a little abdominal pain or chest pain undergoes an endoscopy. So most important is a patient evaluation, and I'm not going to go through that. And these have been done, so I will not go through it further. In United States, it is necessary or essential that you have an anesthetic backup whenever you do an endoscopic procedure. And I know that most of the corporate hospitals today are insisting on anesthetic follow-up. When you are looking at an endoscopic procedure, as somebody is doing, you have to observe not the television screen alone, but you should observe the operator, how he handles the head of the instrument, the knobs, the shaft of the scope, and the body movement of moving towards the patient, away from the patient, rotation of the scope, and the J maneuver. All these are important. I wouldn't go through that. It's very a time you will come across a patient whom you are not able to open the mouth to put in your endoscope. He's got a trismus, but you have to do it. One of the things is you can have a pediatric mouth gag. If that is not over, I'll show you. You can take a 20 cc plastic syringe, cut it, and you can keep it for the safety of your endoscope. Lastly, you pass a 10 or 11 mm Savary-Gillard dilator through the nose and pass a 9 mm endoscope transnasally. If, as I said, if you're not able to get this pediatric scope mouth gag, take a 20 cc syringe, cut it up like this, and you can use it to protect your scope. It's not that it's anything important, but I think it's more important that you protect your scope in a case of trismus. This is a person who had a trismus. We dilated his nostril, put it through the nose, and we did a full upper GI endoscopy. You will notice that when you are doing an endoscopy in an elderly gentleman, the tongue is very strong. They will not be able to get through between the tongue and the palate. Many a time some people advise you to use a tongue depressor to get the tongue down and then pass the scope. That is a little more difficult than putting in your left hand the index and middle finger into the mouth, at the same time protecting your finger from being bitten. And the scope goes through between your index and middle finger to the back of the tongue. I mean, this is a very common difficulty that people face when they are dealing with elderly gentlemen, because we do not want to sedate them to get the relaxation that we require. Now, passing across the cricopharynx is again a little tricky. We usually advise that you go behind the larynx, give a gentle pressure, asking the patient to swallow. It normally works. Sometimes they do not. If you don't want to give any sedation, you press the air-water button down so that a few drops or a cc of water is there in the back of the throat. And if you ask the patient to swallow, he swallows that water. Along with the water, the instrument also goes into the esophagus. Now, other procedures are, you can have a cannula with a guide wire in your biopsy channel, pass it across the cricopharynx, because you do not know whether that area is strictured or has got a membrane across that area, so you do not want to press your endoscope to cause unwanted perforation. Also, as a Jenker's dilaticulum that has been said, we have got to be careful, and so it is easy to pass a cannula with a guide wire, which all of us have, that too with a Terimo type any moist area the cannula with the guide wire will go through. You can use a biopsy forceps, but one has to be very careful. Then, after you have after you entered the esophagus, remove those cannula guide wires, inflate it, get the lumen into position. Do not push the instrument blindly, as it was being done with the rigid scopes. With the fully open esophagus, you go in. If there is a peristalsis, wait till the peristalsis relaxes and then go in. If you look at the anatomy of the gastrojejunal esophageal junction, it not straight down. There is an angulation of about 130 degrees between the esophagus and to the lumen on the of the stomach. If you could see the barium swallows, you will see most of the time that the dye goes at 135 degrees from the esophagus to the stomach lumen. So if you put in straight down, you will be hitting either at the lesser curvature or the posterior wall of the stomach, and hence you have to inflate to see the bit of fluid that is there in the fundus all the time, or you look at the greater curvature with the gastric mucosa all leading towards the pylorus. Next important thing after you have entered the stomach is to suck out whatever fluid is there in the stomach, because in case the person retches and vomits the fluid, there is every likelihood of that fluid getting into the tracheobronchial area, causing severe bronchospasm, much worse infection down below into the pulmonary system. So aspiration of the acid gastric contents always ulcerates the airway, and hence it is essential that we suck out every bit of the fluid before we go further to include the examination of the stomach. As you have already been told, a good inflation and distension of the stomach is important for you to look and examine every square centimeter of the stomach. If you fully distend, you will lose all the mucosal folds. So if you want to go towards the pylorus, look at the mucosal folds on the greater curvature, follow the folds, and it will lead you to the antrum and to the pylorus. So that is one method. Second, look at the peristalsis. When the peristalsis goes in, it takes you to the pylorus. So follow the peristalsis and you will be at the pyloric antrum. Of course, the method of rotating to the left, right, rotating yourself are all there. But visually, what you have to do is these two methods to go on to the pylorus. Second thing you have to remember is that the stomach curves over the vertebral body. So it is not as though that you've got a straight, you've got an undulated stomach to go to the pylorus. So you've got to go over the vertebral body's projection into the stomach to get into the pylorus. So that has to be looked into it. Once you get to the pylorus, most of the time it is closed. It opens up only when the peristalsis reaches the pylorus. So you've got to wait till a peristaltic wave comes to the pylorus, relaxes, before you get into the first part of the duodenum. As I say, you cannot go through a closed door. So if the pylorus is closed, wait till the door opens. Again, the same procedure that you use in the cricopharynx can be used in the pylorus if it is not opening up fully. And again, it is very important to know that the anatomy between the first and second part of the duodenum has already been stressed by Dr. Ishwarmurthy. The position is it goes backwards. First part to second part, it goes backwards. then downwards. And so the reason it goes that way, you have got to manipulate your small and big levers, your body, and the rotation of the scope. That can only be shown and demonstrated on a patient and not by a theoretical lecture. So it's always you'll say small knob down, big knob this. All those things are very easy to say now in the thing. But when you have handled the thing, you've got to know which way the thing has to go. So the first thing is from the first to second part, the scope has to go posteriorly. The tip of the scope has to go posteriorly and then down towards the pelvis. So then once you are there, you already have a long length of the scope in the stomach, and as you withdraw and rotate your body to your right, you will find that there is a forward movement of the tip of the scope down into the second, and many a time you will be looking into the third part of the duodenum. Okay? So once you have done up to that, you are there all the time. Many a time you can see the duodenal ampulla. The difference again, when you look at the first and second parts and third parts are, the first part of the duodenum is bald. There are no mucosal folds. Whereas the duodenum in the second and third part, like a whole of the small bowel, has concentric mucosal folds. That is an important provision or distinction between the first and second part. It's particularly important when you are doing in a person who has had a previous duodenal ulcer and has a scarred first part, shortened and narrow. So that is a place where you have got to know the difference between the first part, second and third parts. Now, once you have completed your examination of these two areas, you do not try to identify the ampulla, but many a time you can see the vertical fold and you can see or imagine where the ampulla is. If there is any pathology in the ampulla, it will project forwards and you can look at it and take a biopsy. Otherwise, the ampulla is best seen when you use a lateral viewing fibroscope, duodenal fibroscope. When you withdraw, distend the stomach as much as you can without making the person belch the air. Once the person belches the air, you start with a step 1 of distending it. Once the stomach is fully distended, you have a panoramic view of the pyloric antrum and the pylorus. And as you withdraw, you make a J maneuver there and you see the sharp edge which has been shown by Dr. Ishwaramurthy in his photographs of the incisor. Tilt your tip towards the pylorus to see the antrum and pylorus. Tilt it up more to look into the fundus and body of the stomach. If you are unable to see the entire body, rotate the scope in the J manner by turning away from the patient so that you have completely rotated the tip of the scope in the stomach and you are looking up the body and fundus of the stomach. The less you handle the larger and lesser wheels, the better, because a longitudinal rotation of the scope does not cause as much damage to the scope as you're using your wheels, because the wheels are controlling by the wires, and so the wires can give way, whereas if you keep it in a J position and you rotate the scope in the long axis, then you will find that the instrument damage is much less. Now, unless you have seen the entry of the scope into the stomach at the top of the stomach and the fundus of the stomach, your examination is incomplete, because many a time GE junction of a hiatus hernia are missed. Now, as I said, the documentation has been discussed. Whenever you've got an area that you are unable to identify, I think we should use a chromoscopy. That is, you've got three types of dyes that are available: iodine, the methylene blue, and Congo red. These three helps you to differentiate a normal mucosa to an abnormal mucosa. Once you spray that, then you are very good in identifying the abnormal areas of the mucosa. Today we were able to show you chromoscopy in the scope that was been recently introduced because of the computer analysis of the mucosa. I don't know, I've not had much of an experience in that, but I would like to prefer to put in these dyes to see the chemical reaction that takes place on the mucosa to identify abnormal to normal, and how much I'm going to rely on the computer the differentiation of the mucosa. Once you have identified abnormal mucosa, take a biopsy, because what your eye may consider a thing, but the pathologist may tell entirely different opinion on the tissue that you are submitting to him. Therapeutic procedures, I'm not going to go further. There are a lot of them that we can do. Nearly 80 to 85% of benign GI lesions are done by endoscopy, by therapeutic endoscopies. That we'll discuss in advanced courses of Efiages. We will not talk about it. When you are taking a biopsy, get your scope as close to the lesion as possible so that your biopsy is a good bit of tissue is removed. You will find that if you have 4 to 6 inches of biopsy forceps sticking out of your scope, it will be wobbly and you may not be able to target the lesion and take a biopsy. Again, in children, I use this towel up to about 8 or 9 years. Put a towel around both the hands and chest so you don't require anesthesia. I call this as a towel anesthesia in children. Very easy, and you don't require much of a procedural difficulties in them. Now, I think this is part of the chromoscopy. Now, if a person has had a gastrostomy because he is unable to swallow, and you are unable to pass the scope through the cricopharynx because of the lesion or stricture, you can pass a gastroscope through the gastrostomy that is there, can go down into the duodenum, pylorus and duodenum, go up the fundus into the esophagus. As you see here, that person is having a gastrostomy. We could not go through. We put a gastroscope. We put a cannula, brought out a guide wire through the mouth, and we dilated it and found out that it was only a benign stricture and not malignancy. Dilated it, then we closed the gastrostomy, and he was able to swallow per via naturalis. So this is one of the methodology of using a gastroscope through artificially induced orifice in the stomach. So if it has a jejunostomy, you can use that also to go both up and down and do a total small bowel endoscopy. So this is a different type of looking at the tube. Sorry. Okay, I think this is all not the thing, except to say that you will have multiple duodenal ulcers which can divide you. I don't think I'll go through this. I'll stop with this because colonoscopy is an entirely different topic altogether, and I will not talk about it. Okay. If you would like to say something, some of you had some difficulties, then we can talk about it.
Thank you, sir. There have been many questions in the morning. How to cannulate a difficult cricopharynx? It's been a repeated talk. And when to abandon? Because you are telling sometimes if there may be a web or there may be something, then you will have to be extra careful. What is your advice for the beginners, and what are the important tricks and maneuvers, especially in difficult patients who try to retch up and
So if you're having a patient who is retching, you have to sedate that person. Particularly elderly ladies, we find that the tongue is very tough to go across, then go behind. When you go behind the tongue, uvula is there at the top of you, and then when you look down, you have the larynx. Epiglottis is in the front, and the two vocal cords go behind, and the cricopharynx at the back, between the tongue and there. So when you look at that, you know the center of the esophageal opening is between the two vocal cords posterior. So if you have that anatomy there, and you put the guide wire and cannula in the halfway between the two vocal cords posteriorly at the level of the cricopharynx, and if it goes in easily for more than 15 centimeters, you can go ahead and do it safely. If you are not able to send your cannula and guide wire more than 2 centimeters, that means there is some other problem which you are not visualizing. Hence, what you cannot visualize, do not force your scope to go through. Do a barium, thin barium swallow or a swallow. Do that, come back and do it. And if you have a facility of a C-arm with you, use that.
thank you, sir.
Have any of the others who have used the endoscopes have had any problems? You can come up.
So now we are welcoming Dr. Satyapriya. He is from Calcutta. He is the Vice President of East Zone and a vibrant Efiages active member, and also he is very passionate. I'm sure he does all the upper and lower, but specifically he has a very passionate about the colonoscopy and the future of advances in endoscopy. He updates himself so much. So he is also giving another lecture tomorrow. So today he will tell all the tips and tricks for doing a colonoscopy. Okay. So even though our thing is, as I said, is a basic level 1 training in the program, still ABC, basics of colonoscopy, one ought to know over the period. And I think with the interest and enthusiasm now, including you, we have now trained 250 fellowship candidates in the last 18 months under the banner of IAGS. So you all welcome. So once we have the 250 people, we need to take you. We need to grow along with you. So that's why false endoscopy, that is fellowship in advanced endoscopy procedure, where we'll be doing more interventional endoscopy and also colonoscopy, and a glimpse of ERCP we are going to do the next stage. That is going to happen sometime in June, July. Then after that, we are planning for a single theme conferences also. So there are lots of things pipeline, and obviously the energy enthusiasm is not only from us, and it's a mutual, it's also coming from, because people are asking, why don't you do this? And so it's all happening parallelly, and any suggestion or anything, lacunae, because feedback form and you fill in, please fill it. So we'll take it seriously, we try to improve and implement. Thank you. Over to you, sir.
Thank you, Dr. Rao, for allowing us to have our third Efiages. I had a wonderful feedback previously. Thanks, Dr. Shameen Naik, and thanks, Dr. Ishar, my very good friend. Actually, under our father of endoscopy, Dr. Professor Krishna Rao, we were trying for a decade to introduce this one, but Ishar actually made it into a reality. Thanks, Ishar, a lot. So, talking after Ishar, whom I feel the best endoscopy teacher in India, and talking after our father of endoscopy, Professor Krishna Rao, is always a challenge. I tell you one thing, when I met with our first DM in West Bengal, Dr. Lahiri Majumdar, he told me that I learned and saw the first ERCP from a surgeon, Professor Krishna Rao. That time I didn't know. I never thought that I can be so close to sir. In Kolkata, we went around the Ganges, going to small hotels and taking ice cream. So now He's like really like our father. He's a great, great teacher still going on. So now we are going into our version of ABC of colonoscopy. So that where I got the Hyderabad pictures. So I bring a lot of our good wishes from Kolkata, Eastern India to your Rajmundry. I think scientific fact is one thing that binds India together. That's I wanted to be. I started my karate classes and 3 months I left it in plus 12, but ultimately become a black belt in colonoscopy only what I feel. So optimizing the work environment is a proper ventilation room should be, appropriate temperature, adjustable lighting system, free of trip hazards, should be adequate space, workplace fastidiously clean between the case and especially at the end of the day, free of distraction as sounds from other room, and adequate workspace for each member of the team, because you need a lot of people in the endoscopy room. So first we should know when we should not do the colonoscopy. The absolute contraindications are toxic megacolon, you know, is bound to be having a rupture is coming, perforation is coming in the way, fulminant colitis, free colonic perforation if you suspect it also, and very important, the patient refuses consent. Many times we don't give it much importance, but now it is coming. And even in between, if the patient says he cannot cooperate with the procedure, please stop it. You don't go on with it. You cannot do that. What are the relative contraindications? Depends on your skill, the acute diverticulitis, inadequate colonic cleansing, the recent myocardial infarction or pulmonary embolism, immediately at least 4 weeks between a post-colonic surgery, and cases of very severe coagulopathy. And the miscellaneous diagnostic indication. I have divided the indications into 2 parts, diagnostic and therapeutic. Diagnostic are the rectal bleeding, overt or occult, iron deficiency anemia persisting and you don't know what's going on, a chronic diarrhea more than 2 months, 3 months is going on, new or worsening constipation. The patient who was not habitually constipated now is having his constipation. Abnormality already found on CT scan, PET scan or barium enema, you are going in for confirmation or for biopsy taking. And surveillance after removal of the neoplasm. Many societies have different methods of surveillance, they have recommendations, but you should know. Then the surveillance in the chronic ulcerative colitis or Crohn's colitis, the first decade, second decade, third decade, there are different indications, different recommendations. Unexplained abdominal or pelvic pain, colorectal cancer screening, idiopathic colitis, determination of the disease extent, its activity or response of the therapy, intraoperative identification of previously identified lesion not apparent at surgery. I was called quite a few times every year by the surgeons, because I am in the surgery department, when they got a report and opened up and they were not getting if the lesion is small, and we did a on-table colonoscopy, showed them the area and then they go on resecting. Therapeutic indications are removal of the foreign body, excision of polyp, treatment of acute or chronic colonic bleeding, decompression of colonic pseudo-obstruction or Ogilvie syndrome. Surprisingly, if you decompress it many times for weeks or months, the patient becomes better. We do not know what's the pathophysiology. Decompression of volvulus, a good number of sigmoid volvulus can be corrected by a skilled colonoscopy. Intramucosal injection of drug, the dilatation or stenting of the symptomatic colonic stricture, benign or malignant, is the bridge definitely, but to resuscitate the patient in a much better way, you have the anemia corrected, have the electrolyte corrected, have the hypoalbuminemia corrected, and your results of resection will be much better. And marking or tattooing of the lesion to be reassessed. In my cases, I do a preoperative colonoscopy just 1 hour or just before entering into the OT and do a tattooing. If you do the tattooing 1 day before, I have seen many of them, the things are not there. And very important thing is to achieve an excellent preparation. I always feel a good preparation is half done colonoscopy. Your worst enemy for a colonoscopy is a bad preparation. So only use a split dose preparation. Now the split dose preparations are there. Screen the patient for history of inadequate bowel preparation or chronic constipation, then consider them 2 consecutive day preparation. Provide clear instruction in native language in various formats. I have a very dedicated team who really knows and they can answer everything. Teach the patient that a clean colon means a high quality examination. Designate staff member for handling pre-procedural questions because you don't waste your time. When most of the times are repetitive, same questions come from them. If during colon intubation, if preparation is found to be inadequate, terminate the case. But you are not going to give a standard result, a report. You can recommend the patient takes more laxative and return, and you can reschedule the procedure with another 2 days preparation. And I must add that many of the endoscopies I have seen, because most of them who are going to distant places and doing the scopies are coming back, are very much negligent about the preparation of the patient. They somehow do and they give a report. Your chances of missing things are very, very high. Even after a perfect colonoscopy, you know within 2 weeks if you do the again colonoscopies or other, 10% patients they can get some newer findings. So without a preparation, how you can give a report? Now sedation for colonoscopy is very important. I always give a midazolam, buscopan and tramadol injection depending on how the patients and other if there is indication. But all over the world, now propofol is the drug of choice everywhere, and propofol anesthesia gives the best result. In states and others, they are making a course so that the gastroenterologists can go there, have the propofol, these few days workshop like thing, they can give the anesthesia of their own because anesthetists are very costly in any of the first world countries. And even the sisters they are giving, as sir was saying, the sisters can give the anesthesia if they are properly trained. Then sedation, few things are there. Target moderate sedation. For higher risk patient, arrange for anesthesia. Obtain sedation related history before colonoscopy like sleep apnea. Now you know the sleep study you can do. Prior difficulty with anesthesia, if any history, be careful. Cardiopulmonary comorbidities, you choose your drugs rightly. Maintain IV access throughout the case. Don't be overconfident. Train anesthetists, train your assistants in signs of cardiopulmonary compromise. Because many of the times you are very dedicatedly looking at the screen and not at the other monitors. So your assistant should look at that continuously. And then utilize the appropriate monitoring devices and maintain required resuscitation equipment. These are the different parts. I am not going to it because in practical classes we can show it to you. But every part is important, and without knowing these things, going for scopy is not good for you. These are the end structures, how we can see, and these are the different channels which are put inside the cover. Now preventing the scope damage in between these cases are important. After washing the scopes, hang them vertically as they have already mentioned for drainage in a protected, ventilated and dedicated cabinet. When transferring the scope from person to person or person to storage location, hold the scope tip carefully so that it cannot drop, because tip has the maximum importance. Then leak test scopes between the cases, because once you miss the leak test, you can severely damage the scope. Train dedicated individual for scope cleaning and maintenance, and quality control of all reprocessing reagents. Don't go on using the same thing. Be cautious about that. Train your assistants. Adhere strictly to the established scope reprocessing process. Educate all clinical staff regarding the proper scope handling, and service the scope regularly also. Always have an annual maintenance scope with the company. They help you a lot. And when passing an ancillary device through the working channel, use gentle thrust and never force. Suppose your biopsy channel is not going, you are in a J maneuver, you are forcing your thing, you are actually damaging your scope. Whenever possible, do not pass ancillary device through a channel when the scope tip is in a retroflex position. Avoid hyper deflection of the dial control which strains the cable. As Dr. Shramati was saying, you change your body position, you twist it, but don't overuse the scopes, overuses the dial control. Avoid suctioning of the large seed or the debris that will very seriously block your different channels. If scope malfunction occurs, switch scope and inform staff about the problem. Optimizing ergonomics is also important. Keep it, they say, around 1.8 centimeter away and elevate the stretcher to a comfortable height. It's around the waist height of the endoscopist you should do, so that it doesn't strain yourself. Like the laparoscopy ergonomics for endoscopy also, you should have that one. And when you start looping, the worst problem of not reaching the cecum is you make loop. Your loop starts from the upper rectum in the sigmoid. Remember that. It always doesn't happen in the later part. So when you are pushing your scope and the image remains unchanged, you suspect it. You push the scope in and the tip is falling backwards. So loop is there, is increasing. Patient experiences pain as pushed. One of them is that. Your assistant can palpate a large loop when putting your hand over the abdomen. Too much scope in patient relative to the location of the tip along the length of the colon. You can see the light, you can see the space. It's 60 centimeters, 70 centimeters, still in the descending colon, sigmoid colon, definitely have made a loop. And the pain during the colonoscopy is very important, related to the mesentery of the colon, is caused by large loops, over distended with air. If the patient experiences pain, first pull it, reduce the loop. Even if it scopes is coming backwards, you don't hesitate, pull it. Remove the air as much as possible. Some people have a habit of keeping the finger continuously on the air channel. You distend as much as you need, don't distend beyond that. And then increase the sedation and the analgesia as needed and titrate the short-acting sedation agent, propofol, so that the sedation and analgesia are the greatest during the intubation when the pain potential is greatest. When you are coming out, your pain potential is not that much. Now, how to maneuver through a narrow diverticular sigmoid colon? Very rarely is a sigmoid truly not traversable due to diverticular diseases. Read the landmarks carefully before advancing the scope. You, on the other hand, determine the location of the lumen. Avoid intubation of the diverticular on face because you can perforate the diverticulum. Use carefully calculated, slowly executed mini moves involving the fine adjustment of tip deflection, torque and axial rotation. All this actually helps, and with time you learn. And how to maneuver through a narrow diverticular sigmoid? Don't ride the air button, as I was saying, that is calling the riding the air button. Irrigate the segment with water. Eliminate the loop whenever possible. Consider switching to narrower scope, like pediatric colonoscope or even adult gastroscope. You do it and then wash it in the Sidex and disinfect it. And repositioning the patient also sometimes helpful. I always reposition the patient. If on 3 times I cannot go, I try to reposition or put some pressure. So why the problems are more in the sigmoid? Because it was shown in anatomically different types of sigmoid loops can be there. So I always say if you can pass the whole sigmoid without causing a loop, your chances of cecal intubation is very high. And now next problem is the intubation of the difficult right colon and the cecum. If problem is there, you are in the transverse colon or near the ascending and near the hepatic flexure, is not moving around. Reduce the loops, utilize the abdominal pressure, including the sandwich technique. That means you are pressing from both sides of the abdomen. Rotate the patient from left lateral decubitus to supine or right lateral decubitus, even for prone one. Ask the patient to take a deep breath, especially when you are in the hepatic flexure. If you take a deep breath, it helps in negotiating into the ascending colon. Aspirate the intraluminal air if using variable stiffness scope. Set the scope at the stiffest. Some good scope have a stiffness things which you can turn near your hand. And when you are in the right side, you can make out, it's very remotely you are controlling. So now you make it stiffer, and if everything fails, withdraw the scope to sigmoid and re-intubate, then you can again go. That's a picture of the cecum. That's another one cecum. You see this is the lumen, that's the ileocecal valve. That the appendicular opening. Now once you are in the cecum, you have almost reached your goal. So there are few reliable and few unreliable signs. For the unreliable signs are transillumination of the abdomen. If the patient is not very obese, you can see in the right iliac fossa the light. Visualization of the prominent transverse fold that looks like the ileocecal valve. With experience, you can look into the ileocecal valve. Indentation of the cecum when abdomen is pushed with the index finger. You push in the right iliac fossa, with the index finger you see the indentation in the cecum also. But reliable signs are appendiceal opening, terminal ileal intubation if you can do it, ileocecal valve identified, intubation or visualization of the villi, notch at the ileal orifice, the lipomatous appearance of the ileocecal valve, and convergence of tinea at the apex of the caput, which is called the crow's feet. So these are the identification marks. Entering the terminal ileum, I won't go, I think it's a little more advanced, but these are the pictures of the terminal ileum. These are the smaller ulcers we found in the terminal ileum. Many of the cases you find that there is absolute normal everything, and terminal 10 centimeter ileum will clinch your diagnosis. These are the different smaller ulcer ultimately found to be Crohn's in the terminal ileum. These are the other one. Okay. These are the other ways how to move into the ileum. Again, I am saying I think it's beyond your syllabus. When we go for the single theme or the advanced course, we'll show it. During withdrawal, first stage of fold encounter, now this is also for the ileal one. Now withdrawal technique, few points are very important. Guiding technique is that you are very cautious and you have ultimately reached the cecum, but you have to see every fold on both sides also. Now there are different other types of newer scopes are also coming, which are giving you the other side of the fold you can look. One is coming out and then retrospective, retroscopes are there. But you don't rush. They say recommendation is take more than 6 minutes time for the convoluted and lengthy colon to take it out. Perform repetitive examination of the blind folds. I'll show you what are the blind folds. Wash the colon thoroughly. If any space, some fecal elements are there. Inspect systemically behind all the folds. Pry apart the apose folds with air or water. And if flyby occurs, that means suddenly you came down a bit. It happens. Sometimes you very suddenly you pass out a long segment. Then again re-intubate and examine suboptimally inspected area. The polyps were missed and 5 blind spots are detected by the literature says it's behind the ileocecal valve, behind the rectal valves of Houston, at the inner knee of the hepatic flexure, between the thickened diverticular folds and the pool of fluid at the splenic flexure. These are the places where maximum number of polyps have been shown to be missed. Now even everything is now over, but even your responsibility is not totally over. The post-procedure tasks are detaching the patient from IV and monitoring devices, transporting the patient to a recovery room. We have a very good recovery room. I think every colonoscopy is not something you do it and throw the patient out. Connecting the post-procedure monitor to the patient, monitoring the vital signs and alertness code. Someone should be there in the room. Allow food as soon as the conscious level is gained. Explaining discharge advices to the patients, recording all intraprocedural medication usage, documenting all elements of the procedure, and recording of any adverse events. See, you cannot conceal if any complication happens. You record it. It's part of the procedure. You do it as Dr. Ishwamurthy was saying, you have to manage it. If you do thousands, you will have complication. You have to rationally manage the thing. And reprocessing endoscopic and ancillary equipments after the procedure. And I'm just mentioning few of the things which are now being used all over the world, not in the clinical labs. One is chromoendoscopy, Sarah already described. The water method of colonoscopy, they say that in many of the cases, instead of the gas, your air or CO2, you can use water, fill up the colon. And they say that reduces the angulation of different curves and your pain sensation is much less, your cecal intubation rate is higher. So that's another method. What I do selectively in some of the bends which I cannot go, I give 300 to 400 cc of MS. And then many of the time I see I can jolly well pass through that part. So then narrowband imaging, we will discuss this thing in future of endoscopy tomorrow. Autofluorescence imaging, then endocytoscopy, confocal laser endomicroscopy, optical coherence tomography. Everybody has its role in some specific cases. And my father, Professor Desharkar, who has motivated me to come into the endoscopy zone, and Agnishika always helps me to make my slides tolerable to you. Thank you, Lord, for the patient here. Any questions, please? Yes, propofol anesthesia all over the world. There are courses and workshops are there where they show them that how much propofol can be used in what patients, what's the body weight of the patient, what are the other problems of the patient, what complication can be there. So these are being officially managed, especially in states. Few of the nurses are there who can do anything, and they are really giving. And one anesthetist, even in the OTs, they have the anesthetic nurses for bigger OTs. One anesthetist used to be in control of the whole OTs. 4 or 5 OTs are going on. So one anesthetist chief, he is rotating, and the other sister anesthetists, they are controlling the anesthesia.
Sir, last year in June 2017, in Efiages Hospital, Somajigoda, 2 doctors are simultaneously doing endoscopies, upper GI endoscopies, sir. But only one anesthetist is present. Unfortunately, one person had cardiac arrest and he was died. And for that compensation, they paid nearly 25 to 30 lakhs for that thing, sir.
See, court cases, now you have to fight a lot. Court cases are not judged by the doctors.
No, sir. From that incident, they told that for every procedure, at least one anesthetist is minimum. So, because anesthesia is involved.
It's difficult to say because we don't have that type of university certified courses. So we may not actually defend in the court that the sister has given anesthesia. But United States, they are all recognized, they have the training there, and they cannot blame you medico-legally because those anesthetist sisters are officially trained. In our scenario, I think anesthesia should be better. Or for the gastroenterologist, like in US, I really want that whether we can make few of our endoscopy one course or workshop so that the anesthetist can come and teach us for one day that which anesthesia, which sedation can be given. Actually, I will talk with Dr. Sharmurthy if we can do it sometime in the future. So thank you all again.
Ishwaramurthy as Krishnamurthy.
Okay, I think we have come to the day 1. There are 2 things about to happen, and after that time for relaxation. One, of course, there is a small assessment for 10 minutes. As I said, it is an essential for all the exam, but even non-exam, have a paper, try to fill in and put it clearly your name, which category or non-exam category on the top right corner, and give it to us once you finish. So you collect it, and we'll just score it. And all the non-exam category, if you wanted to know what's your score, you can get it tomorrow. But irrespective of that, that is only formalities, as I said. After that, I think they are told till 8 o'clock all the labs are open. So you can spend your time, and once the dinner is ready downstairs, wherever it is, and we'll join you there. So I'm sure they made elaborate arrangements, also some entertainments. So it's after a long day, I think we need to have some relaxation and recoup ourselves for another longer day tomorrow. Okay, thank you. And I want to officially release the question paper in the presence of Professor Krishna Rao and Professor Gani Bhaskar Rao and Satyapriya, Kanagavel, everybody. Samir, please come. Join. This is a photo call for all of us. Just.
All the time my question papers are kept in sealed covers. This is the first time we are officially opening the cover.